Thank you. Hello, everyone. Thank you so much for having me speak to you today. We are going to switch gears and talk about prevention, which is not a term that you hear often with Parkinson's disease, but is what I have spent my career focusing on based on my own family history and something I'm really passionate about getting the word out. So most people think that they don't have to worry about diseases like Alzheimer's or Parkinson's until they're in their 60s or 70s, and many believe that there's nothing that they can do to reduce the risk. But these are big misconceptions. Today, I want to give you all an overview of the emerging field of preventive neurology, which really is the future of neurology. Then we'll understand the importance of Parkinson's disease prevention and review the conceptual framework towards preventing Parkinson's disease. And finally, we'll touch on some evidence-informed recommendations to reduce risk of Parkinson's disease. As many neurological and especially neurodegenerative diseases have no cure and limited or no disease-modifying therapies currently available, prevention is not just our best strategy, it's our only strategy right now. Just like our colleagues in cardiology had to push for the field of preventive cardiology, neurologists are finally beginning to realize that we're seeing our patients too late and we're treating diseases too late. So we're pushing to see those who are at risk earlier. This is a very exciting time for our field. I want to emphasize that as we go through this lecture, that there is really no one-size-fits-all approach for everyone. And this is really hard for doctors and advanced practice providers to fully come to terms with because it's not how we were trained. We're trained to treat diseases based on an algorithm, based on guidelines, based on results from randomized controlled trials. And this has worked in the past for many diseases, but for chronic diseases like Alzheimer's and Parkinson's disease, this approach is likely not going to be effective. We have to take into account individual considerations like family history, genetics, and lifestyle factors to really be effective. So let's move on to why is Parkinson's prevention important? So there are nearly 10 million people living in the world with Parkinson's disease, and it's growing faster than any other neurological disease. From 1990 to 2015, the number of people living with Parkinson's disease has doubled, and it is expected to double again by 2040. Along with this, the economic burden of disease, which is already over $50 billion in the US, is expected to double. In 2020, Parkinson's disease rated 14th on the leading causes of death in the United States. And these numbers are shocking, but I do want to take a moment and emphasize that no sum, no matter how astronomical, can really encompass the pain that individuals and families face when they're suffering from this condition. As most of you in this room are already aware, the failure rate for disease-modifying therapies for Parkinson's disease is 100% at this point. And many reasons have been proposed for why this is the case, but prime among them is the shifting understanding of Parkinson's disease as a single entity to recognizing it as a heterogeneous condition with multiple disease subtypes defined by common etiologies or causes, common pathophysiologies, and common phenotypic or clinical features. Therefore, to be successful in prevention of this disease, we have to take a precision medicine approach that accounts for these different variables. In addition to treating this disease with a one-size-fits-all, we've also been treating it too late. Neurodegenerative diseases, including Parkinson's disease, start decades before the first obvious symptom. Typically, by the time we catch Parkinson's disease, more than half of the dopamine-producing brain cells are already lost. So that means that if we catch the disease at age 85, the disease really started at 55 or 65. And if we catch the disease at 65, that means the disease really started at 35 to 45. So we really need to be treating or identifying people earlier in the disease process. This brings me to my next point. We have to distinguish between who's at risk and who already has prodromal or early Parkinson's disease, because that changes whether we're aiming for prevention or we're aiming for disease slowing or disease modification. So Parkinson's disease, as Tammy also already noted in her lecture, is a clinical diagnosis. It's diagnosed when motor symptoms occur, which include a tremor, slow movements, or rigidity or stiffness in the muscle. But Parkinson's disease is preceded by a very long premotor or prodromal period, which can occur 20 years or more before these obvious motor signs. This prodromal period is characterized by sometimes subtle motor findings, but a lot of non-motor symptoms, and this includes loss of sense of smell, constipation, depression, anxiety, changes to body odor, and something called REM sleep behavior disorder, or acting out your dreams, yelling, kicking, screaming during your dreams. In fact, for people who have REM sleep behavior disorder, the positive predictive value, meaning the chance that they will go on to develop Parkinson's disease or a related disease, is more than 90%. And more than a third of people with this disorder will develop Parkinson's disease within just 4 years. So you can see that we know that there's something going on much earlier than we're actually diagnosing the disease. So while these motor and non-motor symptoms can certainly help us identify who's in this prodromal period, with the exception of REM sleep behavior disorder, most of these symptoms are not specific, like anxiety and depression, constipation. These are common. So how do we really find out who's in the prodromal period then? Well, there are fancy images that we can do, like DAT scans, which look at the health of the dopamine cells in the brain. There's ultrasounds that we can use. And now we're having emerging biomarkers that look at alpha-synuclein, which is the toxic protein that builds up in Parkinson's disease, looking at that in the blood, in the fluid around the brain, in urine. So we're getting better at identifying people, but most of these interventions or ways to identify disease are only available for research purposes at this point. There are certain interesting tools, like prodromal risk calculators that were developed that are more practical and can account for the collective effect of having multiple of these symptoms that I mentioned earlier. These are definitely more usable in a real-world clinical setting and can really help figure out who's at high risk. But what about the people who aren't in the prodromal phase and are just at risk? How do we know who those people are? Well, genetics are important here. And you'll hear more in my noon lecture about how much I care about genetics. But there are certain genetic variants in genes called especially LRRK2 and GBA, which increase someone's likelihood of developing Parkinson's disease. And these individuals are perfect because we can easily identify who's at risk with a simple blood test, and usually people will come with a family history of disease. These genetic variants are common, especially in those with Ashkenazi Jewish ancestry. But I do want to emphasize that just because you have one of these genes doesn't necessarily mean you will go on to develop Parkinson's disease. Our genes are not our destiny, but they are very important to consider. For LRRK2, for example, one of the more common variants, the penetrance or the likelihood that someone will go on to develop Parkinson's disease if they have this gene is somewhere between 30 or 40%, but that increases with age. And some studies show that the longer you live, the closer to nearly 100% this might be. So while this is challenging, because just looking at people that have these genes doesn't necessarily mean that we're looking at people who are at risk, looking at these people in the setting of a positive family history and combining other genetic factors can really help us identify who's at highest risk. But we cannot solely rely on a single biomarker to identify who's at risk. So it's necessary to risk profile people, not just to understand who's at risk for these motor signs like tremor and bradykinesia, but who's also at risk for the non-motor problems like cognitive decline, which can happen in up to 80% of people with Parkinson's disease. So, for example, we know that men are more likely to develop Parkinson's disease, in fact, twice more likely to develop Parkinson's disease. And a marker called uric acid is low in those who are more likely to develop Parkinson's disease. So that might clue us in that this person is at risk for motor Parkinson's disease. But people who have REM sleep behavior disorder and white spots on their MRIs of their brain are also at risk for cognitive decline. So when we think about these individuals, we have to target interventions that are promoting cognitive health, not just motor health. And without getting into too many nitty-gritty details, getting more granular about an individual actually helps when we're talking about targeting interventions for them. So, for example, genetics are important, and you will understand how strongly I feel about that towards the end of this lecture or after my noon lecture, but people with the LRRK2 variant have early signs of insulin resistance or early signs that they're at risk for diabetes. And we know that diabetes is actually a risk factor for Parkinson's disease. So targeting insulin resistance early in these individuals actually might help prevent the disease. I put together this schematic. It's called the ABCs of Parkinson's disease risk reduction management, and it's the factors that we have to take into consideration when we're risk profiling people and when we're thinking of what interventions we can use to target prevention. So A stands for anthropometrics. Anthropometrics are measures of body composition. It's really important to understand how much muscle mass an individual has, how much body fat an individual has, but also measures of fitness, so cardiorespiratory fitness and grip strength are key. B stands for biometrics, which are looking at nutritional, inflammatory, metabolic, and cardiovascular disease risk markers, olfactory function, and various imaging studies that I mentioned. C stands for cognitive function. I mentioned that people are at risk for cognitive decline with Parkinson's disease. It's important to know what their baseline is. D stands for DNA or the genetics that I mentioned. E stands for environment. There's a huge environmental component to Parkinson's disease, whether that's toxic exposures, head injuries, which is an overlooked cause for this disease. And as the natives of Louisville will know, Muhammad Ali is a perfect example of how head injury can lead to Parkinson's disease. Stress and other epigenetic factors, biological sex, these are all environmental considerations. And F broadly stands for function, and we're talking about the motor and non-motor function. So in order to really study the effectiveness of using an individualized approach, we developed the Longitudinal program to prevent Parkinson's disease. So eligible people enroll in the study if they have a first-degree relative with Parkinson's disease and are divided into the prevention arm, which is people who are at risk, or the early intervention arm, which is people who are in the prodromal stage of Parkinson's disease. And based on this whole risk profiling, we give them individualized recommendations, and they're followed over time to monitor for progression. So we'll have more data on this soon, but the effectiveness of this approach has been demonstrated in other diseases like Alzheimer's, which I'll talk about at noon if you have time to join my lecture. So let's talk about interventions. What can we do now to reduce your risk? When thinking about interventions, not just for Parkinson's disease, but for neurodegenerative diseases as a whole, I like to simplify it into this idea. The health of the brain and the nervous system depends on two main things. One is the fuel, so the oxygen, the glucose, the nutrients, the vitamins. And two is activation. The brain is a use it or lose it organ. It needs a variety of sensory inputs to help build and maintain these networks of brain cells that connect areas to the brain. And we'll get into this a little bit more as we go through the interventions. I really want to spend a lot of time on this concept of exercise because if there's one intervention that no one will argue has benefit in people with Parkinson's disease and people at risk for Parkinson's disease, it's exercise. So exercise is this activation that the brain needs. Not only does exercise improve mood, energy, sleep, animal studies show that exercise reduces the toxic protein, alpha-synuclein, that builds up in Parkinson's disease and reduces the dopamine brain cell loss that occurs in Parkinson's disease. But the value of exercise is likely much larger in that it also is supporting neuroplasticity, which is the ability for your brain to adapt to changes as you age. But the tricky part about exercise is no one has really been able to define the dose or the type for benefit. And that's because, you probably guessed it, there is no one size fits all for everyone. Let's go into that a little bit more. So as doctors, we really like to focus on this fuel component. We like to think about what nutrients, how much oxygen, what the blood flow to the brain looks like. But for Parkinson's disease, which is a movement problem, I think to be successful, we have to focus on the activation component. So there's a very clear pattern of early motor signs that you can see in people who are at risk for Parkinson's or who are already in the prodromal phase of Parkinson's disease. And a colleague and I have been working with these patients to map out this pattern of movement changes over time and have focused on rehabilitating some of these abnormal movement patterns, which often starts with fixing breathing. Breathing is often a problem in patients who are at risk. Also, this involves getting patients to really sense the left side. We tend to see a lot of rigidity and tightness on the right side, and the left side is kind of left not able to sense the ground and not able to really tolerate load. That allows you to free the right side. We also see a lot of jaw clenching, especially on the right side, and weakness on the left side. So I wanted to show you this video of a woman who likely has prodromal Parkinson's disease, who had a lot of this jaw clenching on the right side. After 5 weeks of myofunctional exercises, you can see her improvement. Let's see if we can get this video to play. Well, okay, that's the toe. Oh, here we go. Okay, great. So you can see the left side of her face is weak, and you could also see the hypertrophy or enlargement on the right side. And you can see after a couple weeks that improved. Is this improving disease course? it's hard to tell, but what I can say is that we're reinforcing the neuronal circuitry. We're reinforcing the neuronal networks so that we're using and allowing our bodies to not forget that that part of your body exists. If you don't use it, you do lose it. And let's go to the next one. Okay, and then this is another very interesting person. So this is actually a doctor. He's 60, he's Ashkenazi Jewish, and his dad had Parkinson's, his paternal grandfather had Parkinson's, and his paternal uncle had Parkinson's. We use this thing called a UPDRS to grade movement. It's not very great in people who are at risk for the disease because it's very subjective. But when you examined him, he had very subtle slowness on the left side. And you can see his walking. Let's see if we can get this to play. You can see his walking. His right arm just isn't swinging as freely as the left arm, and he's not spending as much time on the left foot as the right foot. Hard to see if you're not trained to see this, but take my word for it. We did a DAT scan on him, which is a dopamine transporter scan looking at the health of the brain cells, and it was normal, for whatever that means. After 5 months of programming, you can actually see his walking is much better. He's swinging that right arm more freely, he's spending more time on the left side, and he feels better. Okay. All right. Let's talk about the fuel component a little bit more. So there are certain dietary considerations to think about. The Mediterranean-style diet has the most evidence, and this is a diet that's rich in fruits and vegetables, rich in fatty fish, and low glycemic index foods, which are beans, legumes, whole or minimally processed grains. But there's also certain nutritional elements to consider that there is evidence for, including omega-3 fatty acids, B vitamins, D vitamins, sunshine especially, caffeine in coffee, dietary antioxidants, and flavonols, including cocoa flavonols. We won't be able to talk about all of these things, but if you have specific questions on them, we can come back. So I wanted to spend a moment and talk about coffee because a lot of patients talk about this and they love talking about coffee. I don't know, for some reason, I feel like there was some study on the news that was published that said coffee was bad for you. Coffee's not bad for you. Coffee is actually neuroprotective. In fact, it's been demonstrated that coffee can reduce risk of Parkinson's by up to 60%. And this is a dose-dependent effect, meaning it's about 3 to 5 milligrams per kilogram, which for an average person equals 3 cups per day. So 3 cups per day is protective for your brain. And as you'll hear later, it's not just protective against Parkinson's disease, but also against cognitive decline. But it's likely that there's more than just caffeine in the coffee that is explaining this benefit. We know that caffeine, at least in animal models, is able to suppress this abnormal protein development from being deposited in the brain, but there are other neuroprotective components in coffee, such as something called EHT, that likely explains why it's so beneficial. And while this hasn't been vigorously studied, there's also some evidence to show that the roast matters, with the most brain healthy being the darker roasts compared to the lighter roasts, and the method of extraction might also matter, because when you filter coffee, you're actually removing some of the neuroprotective components versus when you're drinking coffee via French press, which you maintain these neuroprotective compounds. Let's talk about B vitamins, another topic where there's a lot of evidence to support optimizing B vitamins. But before we talk about B vitamins, it's important to understand what this thing called homocysteine is. So homocysteine is a chemical that the body uses to make proteins. Homocysteine is needed by the body, but when levels of homocysteine are too high, it leads to inflammation and the associated health problems that come with that, including neurodegeneration and cognitive decline. B vitamins help break down homocysteine and help recycle it so it can be used. So B vitamins are important not just for prevention of Parkinson's disease, but also for slowing progression in those who already have Parkinson's disease. So please talk to your provider about B vitamins, get your B vitamin levels checked. And again, it's helpful not just for the motor symptoms, but for the cognitive symptoms as well. And since I was on my bandwagon about genetics and precision medicine, I'd be remiss to say that there are certain B vitamins that may benefit people more specifically. For example, this LRRK2 gene, we know that there is a specific isoform of B12 called adenosylcobalamin, which preferentially modulates the activity of this gene, so it may confer neuroprotection in these individuals. So we won't have time to talk about all of these interventions, but I listed them here and we can talk about them if you have any questions, but just to go through some of them, I want to note that while this isn't necessarily a key to preventing Parkinson's disease, it is a factor that we should consider both as patients and as doctors, cancer screening. So we know individuals with Parkinson's disease or those who are at risk for Parkinson's disease are at increased risk of certain cancers like melanoma, leukemia, breast, and colon cancer. Most of these cancers can be screened for, so I really advocate for cancer screening and early detection of these cancers. Mitigating head trauma, again, a really, really important consideration. The earlier age of head trauma, the worse it is for someone. So especially younger individuals who may be in this room, who have a family member with Parkinson's disease, really make sure you're using a helmet, a seatbelt at any high-risk activities. Tammy talked all about stress reduction and mental health. We know that stress is associated with worse cognitive outcomes and a faster disease progression in those with Parkinson's disease. So really focusing on stress reduction techniques can have a huge impact. And then, as I said, there are some specific precision medicine approaches. So if you're here and you have Parkinson's disease and you haven't gotten tested genetically for it, I highly recommend you do, because there's a lot of exciting new drugs in the pipeline and new therapies that can be thought about if you do have one of these genes. So again, I was talking about this LRRK2 gene and the isoform of B12, but there's also evidence to show that NSAIDs, which are aspirin, Advil, can actually prevent disease in these individuals. So that's another consideration to think about in the right individual. So just to conclude, a multi-domained individualized approach may be our best strategy to reduce risk and prevent Parkinson's disease altogether. Further study in a large at-risk and prodromal cohort is already underway with our study LOPE-PD, and I just want to give a special thanks to my colleagues who've helped me and who are involved in my work, Richard and Stuart Isaacson, Beth Lewis, who's an amazing trainer, who's really helped on the exercise and functional aspect of this, and Kiara, who is my research coordinator, who's now in med school, has been a huge help. So thank you to all these individuals. And if there's any questions, I'd love to answer them. Thank you.